auditorium. So it is my pleasure to present Dr. Park. Dr. Park is currently the president of the Korean Society of Endoscopic Surgery. He will be talking about interlaminar lumbar biportal spine surgery. Dr. Park, please share your screen.
Okay, great. Great, thanks for the nice introduce by myself. Can you hear the PowerPoint? Can you see?
Yes.
Yes, we can see.
Okay. Great, thanks, Nikolai. I'll talk about the intralaminar lumbar biportal spine surgery. My name is Jung-Yoon Park. Just call me the JYP because my name is very difficult to pronunciation. And as I say, I work as the WFNS spine committee member. I work in the Korea, the Gangnam Severance Hospital. The biportal endoscopic spine surgery is very similar with the other kind of the endoscopic surgery. The arthroscopic surgery, as shown, this uses two portal, one for the endoscope and the other for the working portal. And the working portal, we can use the drill or every kind of surgical instrument, and that continuous irrigation is the key point of the biportal endoscopic spine surgery. And also we use endoscopic viewing, and also we can use every kind of conventional instrument for the decompression and interbody fusion. Actually, this technique was published at 2030 at this paper called the irrigation endoscopic discectomy. The figure at this paper is very similar with the recent biportal endoscopic spine surgery. One portal for the endoscope and one portal for the instrument. It looks very similar with the recent biportal endoscopic surgery. The concept is very simple. It's very similar with the laparoscopic surgery. Nowadays, the abdomen surgery was changed from the conventional surgery to the laparoscopic surgery. Laparoscopic surgery use the laparoscope just for the viewing. It's the same concept. We use an endoscope instead of the microscope for the viewing. Many Korean doctors advanced the biportal endoscopic spine surgery and published many papers. At first, we are started for the spinal stenosis decompression, but we tried that interbody fusion and recurrent disc herniation or posterior cervical foraminotomy and interbody fusion. Yeah, so nowadays we are possible that every kind of the degenerative spine disease with the biportal endoscopic spine surgery. Okay, today I focus on the basic and the surgical step. The interlaminar approach is that the most basic and important technique for the biportal endoscopic surgery. As you know, the interlaminar approach is not a true midline approach. It's that the posterior paramedian approach. If we said simply the step for the interlaminar approach, we can say that not 8 steps. One for the skin mark and incision and portal making. During the portal making, we must to make the continuous irrigation and then surface dissection and laminectomy with the drill or punch, and then ligament problem removal and the contralateral side decompression. If we do just the discectomy, we do not need to the contralateral side decompression, but for that stenosis decompression, we must do the contralateral side decompression, and then ipsilateral decompression and discectomy and aneurysectomy. I'll show that every step with my case. This case is that the 70 years old female, the right side, the proximal disc herniation. I tried that the contralateral side approach. It means that I start at the left side and then decompress, and then I remove that contralateral side proximal disc herniation. The first step is the skin mark with the CM. At first, we must make a line, the medial pedicular line, and disc space, and the 1 centimeter above the disc line. This portal is for the endoscope. The 1 centimeter below the disc space. This is the portal for the instrument. We call that the working portal. And actually, this portal is deep, about 2 centimeters apart. But if we do the obesity patient, we need more distance between the portal. After the skin incision, we touch that the lamina, and that we must dissect the soft tissue using several kinds of special instruments, but also we can do the very simple dissector. As you see, this is the portal for the endoscope. This is the portal for the instrument. The continuous irrigation input from the endoscope and output through the working portal is that the most essential part for the biportal endoscopic spine surgery. Actually, the proper sufficient inlet outlet is prepared. That inlet outlet is very important. Usually 2 and 3 centimeter distance, and the paraspinal muscle enough dissection. Use the very kind of the dissector through the working portal is very important. And to get more easy the output, nowadays we are use the several kinds of the working cannula like this shape. And I'll show the operation video. The first step, if we after then touch that the lamina, this is the orientation of this surgery, the L3 for left side approach. This is the L3 lower lamina. After soft tissue dissection, we must do the laminectomy. You can use every kind of instrument, a cutting drill or a diamond drill or punch, as you want. You can use every kind of the instrument. This is not the special drill for the endoscope. This is just the Midas drill for the brain surgery. And this is the radio frequency device for the dissect or bleeding control. So I did the laminectomy at the left side, the L3 lower lamina. Every kind of instrument you can use. The laminectomy must be done until you can see the pre-margin of the ligament problem. My plan is that the contralateral side, the approach is so we need a little bit the spinolaminar junction to go the right side. You can see the midline, the ligament problem, the slit, and also you can see that the pre-margin of the ligament problem. And then I dissect the lateral margin of the ligament problem. And then I confirmed the L4 laminar, and also I dissect the lower, the pre-margin of ligament flavum. You can see that the dura at here, we will cut the bone and that the deep layer of ligament flavum. You can free that the lower margin of the ligament flavum. After dissect the upper margin, lower margin, and lateral margin, you can remove the ligament flavum at one piece. Yeah, like this. You can see the dura cell. And to go to the contralateral side, I will do the laminectomy and the spinolaminal junction, sublaminosoplasty. We call that the sublaminosoplasty. We can use the osteotome or drill or any kind of instrument you can use which you like. I prefer the osteotome and drill. I drilled more to compound that the exiting route. This is the contralateral side disc space. Okay, this is the disc coordination. You can see that the exiting route and traversing route, and we find that the rupture disc. And this pituitary fossa is not a special one. This is just a conventional pituitary fossa. And also I use the radio frequency device for the annuloplasty or the ablate the annulus or disc. If you want to the ipsilateral discectomy, also you can do that at the ipsilateral side. After the insert the hemorrhage, the operation was complete. This is the post of MRI, and you can see that the right side, the disc herniation was removed without the tarset joint violation. Okay, I'll show the other case. This is the 79-year-old female, the severe osteoporosis. You can see that the old compression fracture. The MRI shows that the very severe, the 3-4 and 4-5, the spinal stenosis. So for this patient, I decided that the 2 segments, the bilateral decompression with the bifocal endoscopic surgery. So make a line, the medial pedicular line, the disc line L3-4, disc line L4-5. This is the endoscopic portal for the 3-4 disc space. This is the working portal for the L3-4 disc space. And this is the working portal for the L4-5 disc space. The midline portal also we can use for the endoscopic portal for that L4-5 disc space. This is the post-op X-ray. The MRI, you can see that the well decompressed, that's L3-4 and L4-5. After that well decompressed, the scooping of the patient was improved. This is the whole spine, the pre-op and post-op X-ray. The MRI shows that the L3-4 well decompressed. L4-5 is also well decompressed. I think that the most important advantage of the bipolar endoscope is that the bilateral decompression is very safely and effectively. You can see that there was no the facet joint, the violation or destruction. This is the spinal wound. As I say, at first I use these two wounds for the L3-4, and also I use these two wounds for the L4-5 decompression. As I say, the unilateral approach, bilateral decompression is that the most powerful with that bipolar endoscopic spine surgery. After decompress the unilateral side, you can see that the traversing root well decompressed. And then you can move to the contralateral side. This is also the conventional curette, not the special curette for the endoscope. This curved punch, you can see that traversing the contralateral side root. Because of the zoom in effect of the endoscope, we can zoom in very close to the contralateral side. Also, we can do the contralateral side discectomy with very safely. Now I'm using a radio frequency device. I adjust the annuloplasty. Yeah, so you can see that the contralateral side and ipsilateral side traversing root. The MRI shows that the well decompressed the bilateral side and that there was the facet joint violation. Actually, this patient is that the preoperative degenerative rheostasis, but at the post-operative X-ray, the instability did not increase. So, also, this is the very huge disc herniation. Actually, the discectomy is huge disc herniation is conventional method. It sometimes is very dangerous, but using a bilateral endoscopic surgery, we can decompress enough at first, and then we can very safely distract the dural sac, and also we can do the discectomy with very safely. Use disconation, and also we can discectomy with using the conventional instrument. I already did enough decompression. We can distract the dural sac with safely, and also we can use the RF device to coagulate or the sinovertebral lobe. So sometimes it is helpful to decrease that back pain. Okay. Like this way, we can do the bilateral discectomy. As you see, like this case, the preoperative MRI and the axial view. Before I do the bipolar endoscopy surgery, for me this is the fusion indication for me. But nowadays we can do the bilateral decompression, and also we can do the bilateral discectomy with very safely. So we do not need to the fusion surgery. We can do the the endoscopic decompression and bilateral discectomy. And also, like this, the shoes, the unmigrated disc is sometimes is the contraindication with the full endoscopic discectomy, but the biportal endoscopic discectomy, we can do the every kind of the disc herniation. This is also the 5S1, the left side approach. You can see that the X-ray image, and we must explore the superiorly. So I did more laminectomy above the pre-margin of the ligamentum flavum, and then move to the inferior side. I dissect the S1 upper lamina, and also I dissect the ligamentum flavum, the derailleur of at the S1. And then I dissect the ligamentum flavum at the midline and the lateral side. And then we can remove the ligamentum flavum at one piece. Yeah. After remove the ligamentum flavum, I explore the disc space, and I can found the tissues, the migrated disc. I already decompressed the enough space. It's safe. As you know, the migrate disc, we must explore the enough space to prevent that the remnant. So because of the freedom of the instrument during the biportal endoscopic spine surgery, we can explore that the every space, the up and down. So I think that it is one of the advantages of the biportal endoscopic spine surgery. If you can do the bilateral decompression and discectomy, also you can do the biportal endoscopic fusion surgery. After the laminectomy, you can protect the dural sac, and also you can do the interbody fusion surgery. This is the disc space. So you can see that the exiting route at here, I did the total prostatectomy with the biportal endoscope, and then I did the discectomy with this is the conventional life. Remove the disc at the disc space. And then I use the shaver or spreader, any kind of instrument you can use. This is the downbite curette. Also, it's not the special one for the endoscope. This is the conventional downbite curette. After preparate the end plate of the disc space, so we can zoom in to the disc space, so we can confirm that the end plate preparation is directly. And then I put the autobone. I put the autobone at the disc space. And then we put the cage. This is also the conventional cage for tulip. Yeah, every kind of the conventional cage also you can use. Yeah, the cage was located in the disc space. Okay, this is the final slide. In conclusion, the interlaminar biportal endoscopic spine surgery is the effective spine surgery for the stenosis and discectomy and fusion surgery. We can treat that every kind of degenerative lumbar disease. I think that the advantage of the bipolar endoscopic spine surgery, the expensibility is mean that we can apply that various indication, and as I say, we can use the conventional, the surgical instrument. It's very easy and too cheap to the first setup. So, but however, everybody know that the endoscopic spine surgery, we must consider the learning curve, and sometimes if we have a small surgical special instrument, sometimes it's very convenient during the bipolar endoscopic spine surgery. Okay, thank you for your attention.
Great talk, great presentation. Thank you so much, Dr. Park.
Yeah.
It was very interesting to me to watch your presentation and demonstrative videos. I wanted to ask you, I have noticed that you put drain.
Right, yeah.
Do you put drain in 100% of your cases? And if yes, how long you keep the drain inside? Because I'm expecting I'm expecting the cavity that you have created is very small, so that's why I'm asking.
Okay, it's great question. Okay, wait a moment. So sometimes I do not put the drain, but nowadays I put the drain the 100 cases. You can see that these two portal, but we do not need to make the new incision for the drain. We can just use the one portal among the two portal. You can put the drain. Actually, as I say, the continuous irrigation is very important. It means that sometimes the water pressure, the bleeding, or sometimes is masking. I mean that sometimes the operation field is so clean, but no bleeding. But after we stop the irrigation, sometimes there are the bone bleeding or some the hide bleeding. So I always put the hammer bar, the drain for every patient, and remove this drain at 1 day after surgery.
Okay,
yeah.
Thank you so much for that. Is there any other questions from the faculty or from the auditorium before we continue?
Nicola, there are a couple of questions on the chat. You can read them through, please.
Okay.
The chat.
Hi, Salman. Hi, Nikolai.
Hello, hi, Francesco.
Hi.
How is your trip?
Yes, I'm in Madrid, waiting for the next flight. Just to say hello to everyone.
Hello there, Francisco.
Hello.
Hello, Francisco. Yeah.
Salman, I cannot see the questions.
Okay, let me get them out.
I get to the question. So, one question is that in a few cases where there is sign of macro instability in MRI, how do you decide about discectomy versus a fusion?
Pardon?
So one question is that if there is micro instability on MR, do you do discectomy versus fusion?
The indication for the fusion or decompression, you mean that the degenerative listhesis?
Yeah.
Okay. Actually, it is on the trial. I mean that the grade rather than grade 1 listhesis. Nowadays, I just try that just decompression with the bipolar endoscopic spine surgery. So more than the grade 1 listhesis or the dynamic instability, I always do the fusion surgery, but nowadays I try to move to the more the aggressive the patient. I mean that the grade 2 rhistesis, no dynamic instability. I think that just decompression sometimes may be helpful for this understudying, so I cannot sure that this event until now, rather than grade 1 rhistesis and no dynamic instability, I indicate just for the decompression.
Okay, another question from Harshad is, do you advocate biportal endoscopy with facetal hypertrophy with listhesis?
For the facet hypertrophy or the rhistesis?
Yeah, facet, if there's facet hypertrophy, is it difficult to get in?
Actually, the facet hypertrophy is very difficult for the endoscopic fusion, but just for the decompress or dissection isn't not a big problem because we are start from the spinal lamina junction. We don't need to see that the facet joint directly, but if you try that the fusion surgery with a biportal endoscope, you must have a lot of experience with that the MI stellate. So you already knew that the anatomy of the facet joint hypertrophy. If you do not have the MI stellate case, sometimes it is very difficult.
Okay, another question is, how much time do you take for stenosis or a single level disc?
1 hour. That's pure operation time is usually 1 hour. For the disc herniation, I think they rather than 1 hour. For the fusion surgery, is that I need 2.5 hours. Yeah.
And
but
another question is, do you use expandable cage for TLIF?
I use the expandable cage for the MI stellate, but not for the biportal endoscopy surgery because, as you know, expandable cage has a rest space for the bone fusion material inside the cage. So during the MI stellate, I use the BMP, but the biportal endoscopy surgery, as you see, is operation inside the wall. So I worry about that the concentrate of the BMP will be decreased if we use the biportal endoscopy spine surgery. So nowadays, I just use the static cage for the biportal endoscopy spine surgery, but the company try to check that the concentration of BMP in the world. So if we confirm that there are no change in the BMP concentration in the world, I'll try that also the expandable case during the biportal endoscopy spine surgery.
Okay, brilliant. Nikolai, all yours.
There is another question about the use of RF, which I think is interesting. The RF is in the disc. Do you use that to prevent recurrence?
Actually, I use the radio frequency device during the discectomy for the two purposes. One is that the control the back pain. I mean that after discectomy, I always ablate the sinovertebral lobe. It decreases that post-operative back pain. The other purpose is that, as you see, as you say, that it decreases the recurrence. So I remove I do the annuloplasty. And I put the RF device inside the nucleus. So I ablate the nucleus remnant, so we can decrease that the recurrence. It is that essential to use the RF device during the endoscopic spine surgery.
That's great. I think it was a great session, and we will proceed further with the next speaker today.
Okay.
So it's my great pleasure to present Dr. Wu Pan Hung, who is from Singapore, who's going to be talking to us today about transforaminal lumbar spine surgery. Please, Dr. Wu.
Yeah, I'm around. I'm overseas, so I asked Ahmed to help me play out the video, and then in case the internet reception is not so good.
That's great. Okay.
Yes, please go ahead.
Thanks, everyone. I'm Dr. Huang Hong Wu from Ng Teng Fong General Hospital. Today, I will be sharing how I do it, transforaminal endoscopic lumbar spine surgery. I would like to thank WFNS for giving me this opportunity to share my experience in transforaminal endoscopic lumbar spine surgery. It's my acknowledgement and conflict of interest. I would like to thank my fellow, Dr. Rohit Kavishwar, who have contributed significantly to this talk. The aim of endoscopic surgery is to provide a safe and targeted access to decompress pathology with minimal soft tissue trauma. There's few advantages in endoscopy: a magnified visualization, a good working channel that have customized endoscopic instruments that can bypass the soft tissues to minimize repetitive trauma to the soft tissue to the operative field directly. We have a constant inflow and outflow irrigation system to eliminate bone dust, to provide a clear visualization, and to wash away debris. This is an example of a patient who have underwent transforaminal endoscopic lumbar discectomy, TELD, and you can see that he underwent an LA sedation, 30 minutes procedure, and post discectomy, the MRI shows resolution of the disc. And this is a patient who had underwent a lumbar 1-2 TELD, and you can see that the patient can ambulate and go back to work in a very short period of time, and in the 1 year follow-up, pretty much back to normal. Previously, he was very disabled and was wheelchair bound. In the nomenclature, transforaminal surgery focuses on mainly transforaminal endoscopic lumbar discectomy, extraforaminal endoscopic lumbar discectomy, as well as lateral recess decompression and foraminoplasty. Transforaminal endoscopic transcambin fusion is an extension of transforaminal surgery. And you can see from this diagram, the transforaminal procedure are mainly located at a distance from the midline. Essentially, in this algorithm that was published recently in Spine Journal, they suggested that transforaminal surgery will be beneficial in the upper lumbar region for all zones for discectomy. In the lower lumbar region, because of the high iliac crest or a high grade, especially upward migration, so for extraforaminal and foraminal lesion in L5S1, transforaminal is a good choice. The types of transforaminal surgery is essentially very much depending on the approach angle. If you're doing a discectomy, then the 30 to 40 degree angle for the central and paracentral region will be adequate. For extraforaminal, perhaps a steeper angle of 60 degree will be useful. And transforaminal, foraminoplasty and fusion of 40 to 60 degree angle will be sufficient for the discectomy and fusion, the foraminoplasty. In my mind, if you are starting transforaminal surgery, we should probably start in the L3-4 and L4-5 central and paracentral disc. Then we expand to foraminal and extraforaminal disc and other expanded indications. There's some relative contraindications of TELD. Existing nerve root abnormalities such as duplicate nerve root, low-lying nerve roots, high iliac crest, especially in upward migrated disc, may find it a challenge to actually reach the paracentral and the central region of the disc. Pathology related, if it's a very calcified disc and or extensive central and lateral recess stenosis, may actually have implications for beginners in TLD. In terms of equipment, we need endoscope, a fluid pump for continuous irrigation. The irrigation pressure I recommend around 25 to 70, mostly at the 25 to 45 mmHg region. The video endoscopy tower will require video outputs and we require recording system. We need a working cannula of various types, which I will show you, needles, obturator, kerosene ronger, forceps, pituitary punch, pen-field dissector. We need very good radio frequency ablator, drill or reamers. There's some additional devices that can be useful, such as suction irrigation shavers, side firing lasers, atrophying or shaver. So a typical dimension, inner diameter 3.7 to 4.3 millimeter, depending on the size of the task that you are looking at. A bigger inner channel, working channel can always give more powerful equipment. However, too big outer diameter may cause some discomfort to the patient. So we will titrate accordingly and you choose the endoscope of your choice. In terms of working length, if more obese patients, we can use a longer working length. Generally, 170 to 180 is adequate to reach most of the patients in the central region of the disc. As you can see from the various type of working retractors, I typically use the type B, which is the bevel tip, which allows a visualization of both the nerve root and allow a good passing of equipment. The bevel part can protect the traversing nerve roots, while effectively can perform discectomy. The type A will be useful for extraforaminal disc, so that we can actually access directly to the disc and protecting nerve root. There's some advantages of radiofrequency ablation, and using the correct radiofrequency ablation of short bursts can perform hemostasis. There are currently new probes that can actually bend more than 90 degrees, designed by, for example, Bones. We call it Canon spiral probe, recently launched, and it can be bent more than 90 degrees to assess difficult places. Foraminoplasty is an essential part of the surgery. It can be done fluoroscopically or endoscopically. In the inside-out technique, which is popularized by Dr. Anthony Young, is essentially we insert the working cannula directly into intradiscal space, and then working channel subsequently, and perform discectomy from the disc, and then we pull out to perform the foraminoplasty. While that is a very effective system in doing discectomy, there are some limitations. You may have potential to cause exiting nerve root dysesthesia, especially in patients who have very tight foramen. So Dr. Thomas Hoagland subsequently suggested we should do a fluoroscopic guided foraminoplasty, and he designed the Maxmore system with the side rimmer system, which is safe for the existing exiting nerve root. There are also front rimmers by various company that can help in foraminoplasty. Professor Hyo-Sung Kim have suggested that we should use a mobile outside-in technique, which I essentially call it an endoscopic visualized foraminoplasty, which I have employed in my practice. So you can see a front rimmer. The front rimmer advantage is that you can cut the bone facet joint in the front, but there is a potential of injuring the traversing nerve root if we are going too medial, meaning more than medial pedicle line for L4-5 and L3-4, and perhaps mid pedicle line for thoracic and lumbar region. So in Maxmore, they also have the side rimmer, which can do foraminoplasty without actually potentially rimming the traversing nerve root. In terms of endoscopic drill, we have to choose a good endoscopic drill with a slim handle, good pedal. So why we use slim handle is because we want to have less vortex effect. Vortex is commonly associated with rotating motion, and the fluid around the rotating motion can lead to a vortex that you can see from here. A smaller rotation, slimmer handle or holder can lead to a smaller vortex. Additionally, you can see that a slim handle, such as this NSK drill, can visualize very well what is happening around the foramen. While a large, this same transforaminal surgery, a large handle by another company can lead to quite obstruction of visualization. Although we can circumvent by keep turning the endoscope, but it may not be so effective. So essentially, we need to do pre-op planning. We need to find where's the disc. We have to analyze the size of the patient. We want to find out where is the lumbar segment, upper lumbar segment. We have to acknowledge the kidney and the traversing nerve root relationship with pedicle. As we go up in the upper lumbar segment, the traversing nerve root get closer and closer to the pedicle. And then the foraminal size, if it is a very small foramen, then we may have to do a trans-SAP approach where we dock down the SAP and do a foraminoplasty or endoscopic foraminoplasty before we enter the foramen to prevent exiting nerve root injury. And if there's a high iliac crest, maybe we have to consider interlaminar, or we do a special techniques, which will be out of the scope of today's talk. We have to build a safe corridor, and the safe corridor is famously proposed by Kemben and Hijikata, and essentially it involves the triangle that subtends by exiting nerve root, traversing nerve root, and the top of the caudal vertebral end plate. Essentially, we want to be docked in this posterolateral corner region so that we minimize the injury to exiting nerve root or that of the vessels or vascular vessels around the structure in the vertebral body. If we place it too anteriorly, we may injure the exiting nerve root. If we place it too posteriorly, it doesn't reach the target. So the ideal will be the lower dorsal region of the Kemben's triangle. And the trajectory is important. If you are too shallow, then you'll be getting into the spinous. Too steep, then you'll be getting into the retroperitoneal region. So a good angle of 30 degrees will be adequate. But what angle do we use to assess access to the different discs. You can use the average distance or use the MRI measurement to reach the ventral epidural space. In terms of the distance-based approach, Campin and German suggested entry point to be located about 8 to 12 cm away from the midline at about 35 to 45 degree angle. And generally, we accept about 30 to 45 degree angle. Dr. Rutten has suggested in the lower lumbar region that we can consider using a very direct lateral or modified lateral approach, extreme lateral. And we can do it in the patient in a lateral position so that we can have a direct access. Personally, I do not use this approach. You can see from this paper by Dr. Lee, you can see that if he did the analysis at 12 cm and see how much retroperitoneal violation. And at 12 cm, actually, L23 is 75% retroperitoneal violation and major the kidney. And L34 is also not too infrequent, it's about 7.1%, which is quite significant. And then maybe an L45 and L5S1. I think at 12 cm is acceptable with very minimal retroperitoneal violations. Dr. Rutten also recommend not to do at L1 to L23 level. And generally, if at 10 cm from midline, L23 is safe. In terms of lateral view, we can aim our needle to be around the region between the spinous process and the lamina. In our paper, we also suggested that when we ream or when we dock, we try not to dock beyond the medial pedicle line for upper lumbar level, because then the presence of the kidney and the dura expansion together may make it a higher risk of injuring neighboring structure. Overall, we can palpate the lateral edge of the paraspinal muscle, so we try to just be at the edge between the soft and firm part of the paraspinal muscles. Personally, I can calculate it by trigonometry. I use the tangent of the angle. And you can see that if you calculate the tangent, we always know the midline, the disc distance to the skin, which is the opposite part of the tangent equation. We want to know the adjacent sides because that's where the distance that we want to be to get into the disc. So from using tangent, if we calculate the angle to approach the disc is 30, tangent 30 will be the adjacent side distance where we want the needle to be will be opposite side divided by the tangent 30, and then we get that distance that we needed. It requires pre-op planning. This is how we position and how the anesthetists and our X-ray technicians are situated and our nurses. Generally, we prepare the patients in a Wilson frame, radial Wilson table, and for L45, we can position them flat in this way, and we can mark the entry point. This is a video showing how whether the L45 will be parallel to ground X-ray. Okay, go north. As you can see from the video, that the monitor that the L45 is parallel to ground X-ray. Okay, and then you know that this is probably the lower plate of the L5, upper end of L5, and then the lower part of the Campin triangle. Okay, then we do AP view. A lot of the markings depends on the AP view. Pre-operatively, I've calculated based on trigonometry that we need about 12 cm from midline, 12.5 cm from midline to be exact, to get a 60-degree approach angle with this surgery. X-ray, to mark the midline, is very important to get the exact midline. X-ray again. Okay. Sorry, beginner's drawing on your back, okay? So we mark the lower end plate now, X-ray. Can you go more south? More south. Okay, stop there. Always do a little bit. Okay, stop there. Okay, right there. Okay, X-ray. Mark the lower end plate. Then mark the upper end plate. X-ray. X-ray again. Okay, next we will be measuring about 12 yeah, sure. So about 12.5 cm of midline. That's calculated based on trigonometry, will be about here. And as you know from our L45 doesn't have the kidney, so 12 cm of midline should be fine. That's the area, that's the length of the incision needed. So usually I go from the touch upper end plate and aim for the mid-pedicle of L5 X-ray. about there, and then it is here. On the lateral view, we will see. The lateral view, 12.5 cm of hit line, touches the upper end plate and touches the mid-pedicle L5. Okay? So then from here, we see, we know about, we'll be starting from here and in that way. X-ray. Oh, sorry, she is breathing heavily. X-ray. Hold your breath, sir. X-ray. Perfect, right? So this is where exactly we will be like during the surgery. You can see the triangle. This cross is right at the entry of the skin and will be perfect on the Campion's triangle. So overall, we use a 3-step maneuver in inserting the needle. We palpate the SAP, and then we push ventrally into the disc. When we are at the SAP, we inject local anesthesia, and then we push ventrally and enter the disc safely to the medial pedicle line. So this is a video showing how we did it, and then we make an incision on the skin, and then we put the needle. This is the right-sided approach. We now feel the superior reticular process, then we go ventrally and do X-ray. We palpate the superior reticular process this way, and then when we feel the bones in the AP lateral view, then we can actually, according to the AP lateral view, adjust the needle, usually meaning we will pull back slightly and then move ventrally into the medial pedicle line, this space, and then we can inject the indigo kami with contrast. That is an optional step. You can also just put in the guide wire and then subsequently perform fluoroscopic rimming, or directly put in the dilator and the working cannula and perform endoscopic rimming for the endoscopy, mobile outside-in technique. This is a very mobile technique. As we enter and do a foraminoplasty, we drop our hand so they get a more horizontal trajectory into the central region of the disc. So overall, facet is a door, the pedicle is the pivot of the seesaw, as you can see, and we can use that pedicle to lever up and down to get into a suprapedicular root, a foraminal root, or intervertebral root to get into the disc using a levering technique. Essentially, we want to end with a half and half view. Half meaning the top half of the video will show you the posterior longitudinal ligament, epidural space, and the traversing nerve root, and the ventral part, the disc, as well as that of the annulus. Caudally, we typically limited by the pedicle, and of course modified by a pediculotomy to get into a lower migrating disc. Upper part, the working retractor usually protect the excited nerve roots, as you can see from here. Some case example. This patient has a right L2-3 parasite. And then we perform a transforaminal endoscopic endoscopy. L2-3, you need to count levels, or put another wire just to make sure the correct level. And then dock at the Campion's triangle. There's the docking point at the more dorsal, as well as that of the lower part of the Campion's triangle. And you can use an outside-in technique, perform an endoscopic foraminoplasty, endoscopic visualized one. Then we open up this space, and essentially we want to get to the central part of the fragment. So the initial part, when you are taking down this disc may not be the one that actually truly compressing on the nerve root. So limit the amount of discectomy in this area, just to create some space so that you can get into the half and half view. So we do some endoscopic visualized drilling. You can see the foraminoplasty performed by the endoscopic drill. This drill is slim drill with a 3.5 head, and then you can see the visualize the process very clearly. After foraminoplasty, you perform a little bit more discectomy to gain some access space. And then now gradually you can see almost a half and half. You realize that in this outside-in technique there is a little bit more bleeding, so the use of good radio frequency ablator will be good. So now we are removing some disc. To get to the central fragment, you can gradually see that now we are exposing the central fragment. Okay, and then we use a flexible forceps as well as upward pointing forceps to grab the central fragment that is causing the pain paracentral fragment. So now the last bit of the fragment is being grabbed. Bear in mind this L2-3, so I try not to manipulate the nerve too much. And having a very narrow window, we try not to push it so too deep either. But anyway, we can see that it's a well pulsatile nerve root. And using fluoroscopy, we have checked that we have done sufficient decompression of the disc. And then you can go out, position cover, and discharge head out. The next case, also a left L45 TELD. But it's for extraforaminal disc. You can see the extraforaminal region, as well as the foraminal region, there's a prolapse into the vertebral disc. And so we use a more steeper angle. You don't have to go that far away. For L45, a steeper angle, maybe ACM, 6 to ACM is good for short from the disc. You can see when you dock in, you can see the cranial region is on the left, the total region is on the right. It's a left-sided approach, and then you can see immediately this if you use a short from the approach, you can see the exciting nerve very early in the surgery. Have to be careful with manipulation. You can see that on the 9 o'clock position, exciting nerve is very close by. So now we have removed the extraforaminal disc fragments, and we try to release somewhat the exciting nerve so that it's more easily maneuvered to prevent exciting nerve injury. Despite that, I think we find in some studies that there's a higher tendency for exciting nerve injury in extraforaminal disc, so we have to be really careful. Now we do a foraminoplasty so that we can get to the foraminal region of the disc. Again, I like to do this under endoscopic direct visualized endoscopic drilling. So how we know whether the medial margin is sufficient? We actually analyze the beginning of the foraminal ligament, and the foraminal ligament is more prominent than you are probably near the entrance of the foramen. So essentially, as we do the foraminoplasty, you can nearer and nearer, and you can see the more prominent foraminal ligament. And just underneath that will be the trapezius nerve root. So this is where we will do the last bit of the foraminal discectomy. Okay, in this case, you can see that we have exposed slightly on the lateral margin of the traversing nerve root, but not the entire traversing nerve root. The whole purpose is not to do a lateral recess decompression, so that's not necessary to expose the traversing nerve root entirely. You can use the same angle and do a lateral recess decompression, and then you will visualize the lateral recess traversing nerve root clearly. You can see the exciting nerve root is in close proximity of this surgery disc. The wound is pretty small. This amount of this is removed, and the patient is very happy and went home very quickly after surgery. So overall, thank you very much for your attention.
Thank you so much. It was a great presentation, and it was very comprehensive as well. My only question is about your measurement and the tangent that you're using to establish how far laterally you have to go. Yeah, of course, all these, if you start reading about this transforaminal technique, you read, especially for the young colleagues, you read initially about this 8 centimeters, 10 centimeters, 12 centimeters, but of course, this will be variable depending on how big is your patient. If a patient is 60 kilos, and if the patient is 120 kilos, obviously, the offset of the midline will be completely different. So it is, my only comment is you try to get a technique that is not blindly applying specific centimeters, but try to adopt a technique that is taking into consideration the specificity of the patient. How big is your patient? How small is it? I personally don't use your tangent technique. I use the supraspinous and suprafacettal line for a rough orientation, and then obviously I will modify. I will be closer to the supraspinous line if my disc is more lateral, and obviously if it's more medial, I will go further down. If you go below the suprafacettal line, it is already becoming dangerous that you will go inside the abdominal cavity and maybe damage organs. What is your comment on that?
I think that is a very good comment. I think most of the workshop that we go for, most of the literature that we read is exactly like what Dr. P. Nicolai mentioned. We use the lateral view, and then we decide, usually most of the discs are between the line of the spinous process and that of the line of the facet. Usually in that range is pretty safe and you can get most of the disc. And then I have two comments. One is that if we do that, then we tend to take more X-ray, okay, because we have to really get the lateral view point. Of course, that in experience hands just maybe 2 or 3 more shots. Second point is probably my trigonometry is an additional adjunct. it gives you more confidence in the beginning of the operation to actually, I'm let's say 11.5 cm or 13 cm, more exact number off the midline, and I will get to the disc. And true enough, I did in my own series that, it's not published, but I did enough to also using Dr. Peve's technique, and they usually all roads lead to Rome, and just tell you with more confidence that this is the correct region, more from the midline, that you can get to the trajectory. So I wouldn't say this is the best way, but it's something quite, you can spend 2 minutes or 3 minutes before the operation looking at MRI, and you get more confidence in the trajectory. Why I spend quite a number of minutes in this talking about docking? I think transforaminal surgery, and Dr. Park show a wonderful biportal surgery. I do biportal surgery myself. Biportal surgery is a floating technique, while transforaminal surgery really needs to be very precise. Of course, that gives a lot of advantage, like awake surgery, local anesthesia surgery. However, we need to really be quite close to the target. We can't be docking to Mars and hope that we can get to Moon, because you will have a higher incidence of inadequate decompression. So we spend time pre-op and best possible to put our endoscope as close possible to the target.
Well, that's great. Yeah, so I completely agree with you. Whatever technique you use, try to use a technique that that is taking into consideration the patient that you're operating. Of course, your technique is very highly sophisticated, and it is very precise, and it's more reassuring. But if you hate mathematics like me, then you can use something else. Okay, so let me see if there is any. There is a question here. What is your most common complication doing transforaminal lumbar fusion? That's a question here. That is, do you do transforaminal lumbar fusions and endoscopic? And what is your complication?
I use the posterolateral approach, which I take out the facet joint using a stenosis-scope. If I do uniportal, or if I do biportal, I do what Dr. Park shows. I personally don't do transcambine fusion, meaning that I don't just do I don't use a transforaminal scope for foraminoplasty and then insert a usually expandable cage. My comment from the literature, which I review and wrote, is that the incidence of exciting nerve root injury are higher in transcambine fusion, and possible subsidence higher in transcambine fusion, meaning we use a transforaminal root with a small scope. I think there are two reasons. One, obviously, as you can see from my the second case, we are pretty close to exciting nerve root once we do a transcambine fusion. If an inadequate foraminoplasty is done, we are really forcing a cage, a typical AP diameter of possibly 7 to 8 mm, and some even put larger, really squeezing into the very, really close to exciting nerve root. If we don't have proper cage glider, then we really have a possibility of crushing the exciting nerve root. So that is one of some criticism of that technique. Of course, in expert hand and adequate foraminoplasty currently, then such technique and expandable cage may decrease the rate of that. And second part about end plate subsidence, which is one of the criticism of endoscopic fusion and mostly get from the transcambine fusion, is that we actually, majority, I think in the majority of people who do transcambine fusion are doing the discectomy or disc preparation under fluoroscopic guidance a lot more than the scope guidance. So they do fluoroscopic guidance, cage preparation, end plate preparation, and then use the scope to double check. So there are possibility of end plate fibrillation. I'm not sure. Of course, in expert hand, again, that can be prevented. And I think Dr. Michael Wang and a number of people who have shown very good results. So These are two main criticisms. I think the posterolateral fusion, which is more quite popular in the world now, especially with the advent of biportal endoscopy, we sec the facet joint and get to very much like what we do in Harm's technique in my tubular fusion. So in that way, of course, in any Harm's technique, then we'll be talking about maybe a bit or more risk in the traversing nerve roots, and then dural injury, dural tear. But having said that, I think in good hands, that is quite low. So overall, I think both are good fusion technique, just steep learning curve, and it will be very interesting to see which one has better results.
Thank you. What is your comment on exiting nerve root dysesthesia? Do you have many of those?
Exiting nerve root dysesthesia is more common in transforaminal surgery when there is foraminal stenosis. So I think personally, I have a few that has usually related to extraforaminal disc. So I typically don't inject steroid or Marcaine in any cases of the patient. Marcaine, of course, for LA, but not for nerve calming the nerve root at the end of surgery. But in exiting nerve root, I mean in the extraforaminal disc, I will do that. I shift a little bit of these cases to revision ones to biportal so that I can do the floating technique instead to prevent exiting nerve root dysesthesia, but that's a separate topic. I think we have to be careful. You can consider using the fully protected tube rather than the bevel tube. That may be one of the ways to do it, but is this more disorienting? But this one thing we have to analyze before op. If the foramen is very tight and there's a very severe stenosis, the traversing exit. If it's a very severe stenosis, the traversing and nerve root will be pushed more medially. You have to be careful in rimming, in terms of preventing traversing nerve root injury. If it's a very tight foraminal stenosis, then we can consider docking onto the SAP, superior articular process, and drill or rim it really directly on the SAP rather than trying to dock into the cambium triangle into the disc, because that is one of the cause of exiting nerve root dysesthesia in my mind.
That's great comments. And I think probably we will get one more question and then we'll go ahead. Local versus general anesthesia. What do you do? I think
for transforaminal surgery, the purists will do it under local anesthesia with sedation, because then you can eliminate the need for neuro monitoring. The person can the patient will feedback to you if the exiting nerve root is getting tight or the traversing nerve root is getting tight. Of course, for beginners, it's quite unnerving if you take more than 1 hour for 1 or 2 hours on transforaminal surgery. Then the patient get a bit not too comfortable lying in prolonged duration on Wilson frame. But if you get through that, then I think it's actually safer for the patient. In neuro monitoring under GA, whatever the neuro monitor tells you, it will be probably a minute or two later than what you have already done. So I think the real-time feedback is important in the LA sedation transforaminal surgery.
I personally started with local myself, and then now I do everything under general anesthesia. I don't know, maybe I did not get a proper anesthetist that is working better with me, and then the patients were sometimes moving, and then when the patient starts moving, then you will lose the well-centered X-rays, and so this was my main reason to go to general anesthesia. But definitely local has the advantages what you said, but also I found also that I have to, sometimes the patient is not suitable because of being very, very scary about local anesthesia and feeling what's happening there. Although, you know, the sedation will help with that, but still, that is what happens.
I would like to comment on that because I had a recent case. I removed a cement in the L1-2 region under local anesthesia sedation in an elderly lady. she has no pain after all, but she wrote a complaint letter because she said during the procedure she was anxious, and then when I took out the cement from the traverse near the traversing nerve, there was a period that she feel pain. And if the disc or or for this case, the cement is very stuck to the nerve, then really, no matter how much LA you give, the patient will be uncomfortable. So I can't agree with you more, and that's my probably one of the only complaint I ever get from transforaminal surgery. It's very upsetting because I remove the cement, difficult case, and she has complete relief of symptoms. So yeah, we have to be very careful when we advise patients.
Okay, so thank you so much. It was great discussion, and I think we're gonna move to the next speaker. Francesco, do you want to present Kim?
Yeah, do you hear me?
Yes, yeah, we are.
Okay, because I'm working both with the headphone and the computer, so I don't know if it's working very well. So the next speaker is Professor Kim from Korea, and sorry, I don't have the program, and his topic is sorry, I have it because I said, and his topic is foraminoplasty with the endoscopic view. So please, Professor Kim.
Yeah, hi everyone.
Hi.
Yeah, can you hear my sound?
Yes, very well.
Okay, okay, thank you so much.
We are able to see your screen, your desktop.
Okay, now you can see my slide. Can you see my slide?
Yes.
Yes.
Okay. Okay. Thank you so much, Dr. Nikolai and Salman Sharif and Dr. Costa to invite me and to give a chance to talk about the endoscopic spine surgery. Actually, before Professor Jung Yun Bak and Pang Hong were talking about the approach of the endoscopic approach and transforaminal approach. And before time, the main concept of endoscopic spine surgery mainly targeted to the disc pathology because of that transforaminal approach and intraforaminal approaches became a main surgery endoscopic approach. But nowadays, endoscopic spine surgery is spread more widely, especially spinal stenosis. Because of that, nowadays the decompressive approach for degenerative spinal pathology using the endoscopic approach will be the mainstream in the future. And this time I hope to talking about lumbar foraminal stenosis decompression, and also in the I believe that to solve this problem of lumbar foraminal stenosis will be the near final step of endoscopic spine surgery to popularize the spine surgery. And also, I will talk about the three kind of foraminal approach using the endoscopic surgery. And firstly, we should about the biomechanics of foraminal pathology, because of that before time we knowing that the result of foraminal decompression is not good in spite of the open surgery and also in spite of the endoscopic spine surgery, because of that there have so many complicated biomechanical consideration. Because of that, should checking this biomechanical consideration will be the first step to understanding to overcome the foraminal pathology by the endoscopically. And we are already well known that there have in the foramen there have several anatomical structures that will be compress the nerve root, like some disc protrusion and thickened ligament problem and orthopedic point and some collapsed intervertebral space. They will make foraminal stenosis. Because of that, to decompress these all structures sufficiently, that will be the key point to success the foraminal decompression. And additionally, we should check in some another important point of lateral wedging instability, meaning that the lateral instability with the wedging of the foramen. Because of the so many foraminal pathology usually combined with the lateral wedging, because of that, if we not consider this problem basically, that will not easy to take excellent surgical result in spite of the endoscopy or open approach. And this near similar concept of lateral wedging instability. Because of that, with lateral wedging instability, we can estimate there have not only foraminal stenosis, but also sometimes extraforaminal stenosis, sometimes paraspinal stenosis combined together. Because of that, to understanding this lateral wedging instability in the foraminal stenosis is the main key tips to understanding the foraminal pathology. And firstly, we checking the approach point of the endoscopic foraminal decompression. As at the initial time, the foraminal decompression of the full endoscopic approach only try to transforaminal. Because of that, that time the knowledge and the surgical techniques of another approach is not developed. Because of that, the first time we docking the working channel transforaminally and decompress this some narrow foraminal space by the endoscope drill and sometimes forceps, but there is an allergy at that time. Because of that, I already mentioned that the foraminal pathology not only happen in the thickened ligament osteophytic bone structures, but also there have so many other structures. Because of that, clinical result is not good in the transforaminal approach. Because of that, after some developing some contralateral intraluminal approach to overcome this problem, contralateral intraluminal approach introduced to overcome these problems of transforaminal approach. Using this contralateral approach, some doctors like me tried many times, and also their report, my report, and their report talking that contralateral intraluminal approach can take a more good clinical result using the transforaminal approach. Because of that, there cannot aggravation of the lateral wedging instability, but also they can make a more sufficient decompression of foramen, and also they can manage the thickened ligament problem together. But unfortunately, with this development of the contralateral intraluminal approach, that is not popularized in the clinical endoscope field. Because of that, this technique is actually most weak point is that the learning curve is very steep. Because of that, some learn is not easy. Only some doctors can try that. Because of that, to overcome these two problems, maybe nowadays I believe that so many doctors try the posterolateral approach rather than the transforaminal or contralateral approach. Meaning this posterolateral approach near a steep angle and make a near to the facet area and decompress this foraminal area by using the posterolateral approach. And then can consider, we can see that this lateral wedging instability make foraminal stenosis. And to overcome this problem before at the initial time, the resection of shippractical process, some part of shippractical process, and not managing the this thickened ligament ligament problem is not in transforaminal endoscopic compression. And to overcome this problem, the contralateral intralaminar approach introducing the foraminal decompression. I already mentioned that it can make a more wide decompression of foramen, and also it can manage the foraminal pathology together. But this also have some steep learning curve, and one additionally that usually it need some manipulation of the disc space, because of that it also have some chance of recurrence and sometimes restenosis again. To overcome this problem, I already mentioned that nowadays this paraspinal approach introducing the field. Today, I will talking about these 3 different techniques, and this paraspinal decompression. This also can resect the shippractical process and some part of the lateral part of lamina. And more importantly, this technique can manage the foraminal ligament near completely, because of that this technique can decrease the recurrence more sufficiently. But this 2 transforaminal approach has a more higher chance of post-operative disadvantage rather than the contralateral intralaminar approach. Contralateral intralaminar approach has some less post-operative disadvantage, but it has I already mentioned that there is a more steep learning curve. Yes, firstly, we're talking about the transforaminal endoscopic decompression of the transforaminal way, not posterolateral way. Usually, this technique already introducing so many professors like Tony Young and Professor An, and they talking that some decompression of foramen, they can take a good clinical result. For example, like this case, sorry. You can see here the foraminal stenosis, and then yes, you can see here firstly docking the working channel to the disc space. After then, move to the foraminal area. After then, expose the tip of the shippractical process there, and here of the ligament, foraminal ligament, and then drilling the some part of the shippractical process. Using this technique, we can estimate that can save the facet joint violation near completely, and also can possible decompression of foramen. But I already mentioned that this is not easy to manage the foraminal ligament, because of that. In spite of the sufficient decompression, resection of the shippractical process, there needed some more management of the disc space and incomplete decompression of foraminal ligament. Because of that, and also some another weak point of this transforaminal approach in the pathology is maybe some manipulation of lateral wedging instability. Because of that, after some, the operation, the patient, after some working, the restenosis happen more easily. And also because of that, using this technique, or in my clinical result, the success rate is not over 80%, and it meaning that there have so many still not complete surgery. And anyway, possibly you can see the wide decompression. This is the case of foraminal disc and the foraminal stenosis cases. You can see this L4 with this type of shippractical process. Firstly, taking the work channel transfer move to the shippractical process. Then this tip of the process, then you can see the resect some part of femoral ligament. But at the time, I believe that is a excellent, and I that we are the excellent clinical. I mentioned using this technique, I'm only take 80% of clinical success rate at the time. What is the reason I cannot make more than 95% of success rate? Because of that, I moved to contraintramural approach development. And anyway, you can see there's some tip supra some part of some problem resect here. And you should knowing that this primary approach is first step to start endoscopic compression. This is some learning curve is not safe because that we time we try the primary approach because of the technique can be anyway. This patient can see sufficient decompression and post-operative take a good result. This another cases of femoral stenosis. Actually, I changed. I tried some contralateral internal approach and nowadays postural approach due to this patient. Because of that, you can see that this patient have so severe lateral wedging instability, and after operation, I believe that this is sufficient, very nice decompression. But unfortunately, this patient after standing and walking some months with stenosis again, and the patient pain not gone near completely. Because of that, this patient needs some fusion surgery, and also I experienced some another cases also similar result like this lateral wedging instability. Because of that, like this lateral wedging instability, I believe that the contralateral approach or only femoral spinal decompression will give the more good clinical result like this case. But this is not a wedging instability cases. Transfemoral approach also can take excellent clinical result. And anyway, then I tried the contralateral approach and like this. Firstly, docking the working channel lateral, and to overcome contralateral using the over the top technique, and to decompress the contralateral foramen. And it should some resect the ligament problem completely, and some resect the some superior process, and some during the some part of the inferior process, and sometimes some during the contralateral disc space. Because of that, it has also steep learning curve, and also it needs some long time operation time. Because of that, in spite of the surgical result can take a good result compared to the transfemoral approaches. Sometimes this technique is not easy applied to the patient in like some multi-level cases or some so severe stenosis cases. And anyway, this contralateral internal approach can possible decompression of foramen near completely without mobilization of the lateral wedging instability, and sometimes can easily more sufficiently manage the ventral part of the contralateral foramen like this. This is procedures like this. Yes, you can see this paper also published by me and my colleagues, and in spite of the L5 some foramen, extra foramen can pass over to the like this contralateral internal approach, and you can see the contralateral active nerve root and contralateral extra foramen can pass over. It meaning that the contralateral far lateral space also decompression can pass over by then endoscopically. And you can see like similar cases of L5S1 can see the where decompression of this lateral recess foramen and extra foramen can possible. And also my study using this, compare these two techniques of transforaminal decompression and contralateral intraforaminal decompression, there is more advantage in decreasing the postoperative dysesthesia in contralateral intraforaminal approach. And you can see here the some demonstration, illustration. You can, sorry, tucking and contralateral love, decompression and contralateral extra foramen here. Then possible to decompression like this. And you can see here the, sorry, okay. This patient also 71-year female patient with degenerative scoliosis with the severe foraminal stenosis with the central to lateral recess stenosis and foramen extraforaminal stenosis. Now you can see the full video of the, here is a contralateral foramen, this L4, this L5. I mean that this tip of supraarticular process of L5, ipsilateral and contralateral. Firstly, this intraminal space, disc space of the contralateral area. This after final decompression, you can see the free exiting nerve. This resected supraarticular process and this contralateral foraminal ligament. And this ventral part of the contralateral exiting nerve. After then, you can see like this image. And this patient followed more than 2 years, and the patient have no pain and no aggravation of degenerative scoliosis. And also nowadays, I tried a paraspinal approach. And actually, this technique already introducing Korean doctors, Dr. Chol Lee, and he published his technique in the textbook of Advanced Techniques of Endoscopic Lumbar Spinal Surgery. And also, you can see in the foraminal stenosis with some osteophytic bony structures. To the supraarticular process completely and resect to the foraminal ligament completely. Nowadays, yesterday, maybe 2 days ago, I presented this technique in the Korean Neurosurgical Society, and I named this technique selective. Selective supraarticular process resection technique foraminotomy, and this my result. And you can see using this technique. Most some worry about this technique. Maybe many doctors will worry that it may be some have some chance of facet joint damage, and it may be some aggravation instability. But you can see this is my patient preoperative and postoperative. You can see the compression of a supraarticular process, but fortunately the facet joint is not damaged more seriously, near completely, and also maybe in the long-term follow-up that have no aggravation of instability due to, in spite of this decompression is completed, but this foramen is saved near completely. And also some other cases can show the similar cases of foraminal decompression, they're completely after operation, and but there have no aggravation of the damage, no serious damage of the facet joint in spite of the sufficient decompression, because of that instability not happen so seriously. And this is the clinical result of VAS ODI magnet, and also you can see the foraminal width and facet joint saved near completely in spite of the sufficient foraminal decompression, and also maybe 6 months later, you can see some remodeling of this facet joint again. Because of that, it has not serious to aggravation instability or not serious to damage the facet joint in spite of the sufficient decompression like your facet like this. And also there have no aggravation of the lateral wedging instability and this kite collapse, meaning that in the foraminal pathology, we can save the instability component with the sufficient decompression using this post-lateral approach. But most weak point is that this technique is still it have some worry about the post-operative dysesthesia. But fortunately, this dysesthesia disappear maybe 1 or 2 months later, and 6 months later it disappeared completely. Because of that, we recommend to the patient it have some chance of post-operative dysesthesia. After you overcome this, that time you can take a good clinical result. And anyway, there have no also some lumbar motion of the lateral flexion extension also improved significantly compared to preoperatively. And you can see here some selective, this suprathecal process only resected this suprathecal process selectively, and foramina, this now resection of the suprathecal process only, and also resected the ligament, foraminal ligament only. And then after removing this foraminal ligament, you can see this L4, L5, and L4 lobe root. L4 lobe root. Now you can see the free exiting nerve root. After clearing, you can see the free nerve root is freed completely. And also you can see the cases of this selective suprathecal process resection of this foraminal sinus cases. Now you can see some resection like this, but SAP removed completely, but facet joint saved near completely. And another cases of the some lateral recess stenosis, foraminal, extraforaminal stenosis. This patient combined the contralateral decompression and the transforaminal posterolateral paraspinal decompression together by the both sides. You can see the after operation, the foramen decompressed completely, and you can see the then in spite of decompression completely, the facet joint saved near completely here, you can see. And another cases of central stenosis and foraminal stenosis together case, you can see this patient received the foraminal decompression and central decompression same times at the same side. And after operation, you can see the central decompression sufficient, and also the facet joint saved near completely in spite of the central decompression and facet joint decompression together. In conclusion, yes, there have 3 kind of foraminal decompression, endoscopic decompression technique of transforaminal approach and contralateral intermal approach and paraspinal approach. I already mentioned that there have some 3 different advantages and disadvantages. Because of that, you should choose one of them for the foraminal pathology. For beginner, I believe that some transforaminal approach will be the most easy, but after expert, maybe contralateral and paraspinal approach can take a more good clinical result. And also using the paraspinal approach, it can, in spite of the post-operative dysesthesia, at the long-term follow-up, the patient clinical results, in my clinical result, maybe more than 95% foraminal clinical result can take, it meaning that the re-stenosis not happen near completely, and also revision surgery also decreased so much in my cases of using the paraspinal endoscopic foraminotomy. Yes, in conclusion, there have three kinds of transforaminal, contralateral, paraspinal approach, endoscopic approach for foraminal pathology. And before we should consider the lateral wedging instability, and we should decrease the related violation, facet joint violation, and should sufficient foraminal ligament and foraminal stenosis decompression should be done. And if possible, do not touch the disc. Because of that, I like the paraspinal approach. It can make some preserve the facet joints, and in spite of the technique, the foraminal pathology commonly happen in postoperative dysesthesia. Because of that, we should recommend to the patient. And if we decrease this postoperative dysesthesia, we can recommend the contralateral interlaminal approach and some part of posterolateral paraspinal approach. I like this talk of the things that seem to last forever changes suddenly one day. We should prepare for the next generation of spinal therapy using the endoscopic surgery. Thank you for your kind attention.
Thank you so much, Kim. As usual, very comprehensive and very interesting. There is a few questions from the chat. Bilal Mirza is asking how many patients you do open? Do you still do open minimally invasive surgery, or you do all endoscopic?
Yeah, I'm doing maybe spinal surgery monthly, minimum 60 cases to maximum 80 cases. Among them, the open surgery maybe 1 or 2 cases, maybe by the 2 or 3 months. It meaning that maybe per year, my open surgery less than 5 cases. Only open surgery, cervical HDF and cervical laminoplasty and lumbar corpectomy and thoracic corpectomy cases only. In another, all cases can possible endoscopically.
Whatever is not possible, it's the possible that takes more time. That's my comment to that, to what Kim just said. I'm saying that in the beginning, what feels impossible with experience, it becomes possible. So that's
yesterday I'm talking on the Korean YouTube, very famous YouTuber. I'm talking that so many doctors worry about that your technique is very difficult and that is not easy to learn. But I believe that in the some starter and beginner, they developing good technique. The always follow that way. I saw so many followers like Dr. Wu and so many doctors. They can possible at the initial time. That is not easy, but at the time they can possible. Don't worry that.
Another question from the chat, Kim. What are the risks? So no, before that, there is another question from Petra. What are your selection criteria for transforaminal versus the contralateral sublaminar approach?
Yes, I already mentioned that maybe there have some stabilities near completely stable. I sometimes I recommend transforaminal approach, but the lateral wedging instability is some serious. That time rather than I choose the contralateral approach. But recently I tried so many paraspinal approach because of that the operation time is so rapid. But maybe the operation time of transforaminal approach usually need more than 30 minutes, and contralateral approach needed near 1 hour. But transforaminal paraspinal approach needed less than 20 minutes. Because of that, nowadays I like the paraspinal approach.
Okay.
Okay.
Thank you so much, Kim. Again, very, very fascinating talk. And
Yeah, I have one comment that I hope to see you again for World Federation Spine Committee members again.
Of course, for sure. So I think that we can conclude for today. It was a very interesting session and a very good participation. We were at one moment over 190. We are still 186 at the minute. So great interest, and obviously no wonder we had great speakers today. So I think the last thing that we should not miss to do, otherwise we may have been might be scolded by Salman, is we have to switch the cameras and smile for a group picture.
Salman.
Kim, good to see you.
Everybody say transforaminal approach and smile.
Yep, thank you, everyone.
Okay.
Thank you. Thank you.
Okay.
Thank you, everybody. Bye-bye.
Thank you so much. Hope to see you again as soon as possible.
Sure.
Yeah.
Yeah.
Thank you. All the best. See you soon.
See you soon.
See you.
See you.